will continue to trickle in for some time. That's invariable.
Yes. So, good evening, all, and it's indeed a pleasure to welcome you all for this month's Journal Club. We have a very interesting article that is selective trial and large core infarcts. So far, we are not subjecting them to endovascular therapy. So now this trial and one more trial which has come some time back, that is Angel Aspects trial, which is a Chinese trial. Both have looked at the large core and whether we can do EVT and what will be the lowest aspect score to which we can go and what is stroke volume. So all these aspects will be discussed in detail in today's Journal Club. And I hand over to Dr. Sunil to take it forward.
Thank you, Dr. Gothi. So IN stroke subsection is one of the important academic activities, has been this monthly journal club. And this is a very educative session, especially for stroke neurologists and postgraduates doing DM or stroke fellowships. And we have been having fairly good and active participation so far. And this month, the team is from CMC Ludhiana, Dr. Pandin and his team. And a very important topic, as Dr. Gothi already introduced, once we got the opportunity to extend the window beyond 4.5 hours with thrombectomy, and then we found that the thrombectomy is effective even up to 24 hours in Dawn and Diffuse 3 trials. In these trials, we are a little, understandably, a bit conservative, selected patients with a fairly lower innate stroke scale and higher aspect scores, so that the infarct volume was not too big. So that precaution is quite understandable in the early stages of extending window to such a large level. But the fact remains that around at least around 20% in documented data, patients do have larger scores when you are attempting a procedure like this at as late as 24 hours. And they were all not getting the benefit of thrombectomy if it is beneficial. And that's when this attempts at doing it at larger core volume of infarcts started. And it's a very, very important trial from its practical value. And in fact, very high practical value because of the impact it can have in real life when to centers where thrombectomy is available, and therefore to improve the patient's support in a devastating disease like stroke. So I would now hand over to Dr. Pandin to introduce the team, his team, and to also start with the proceedings.
Yeah, thank you. Thank you, Dr. Gothi and Dr. Sunil, for giving us the opportunity. And I have Dr. Rajeshwar, who is Assistant Professor of Neurology, and he also does neurointervention in addition to the other neurointerventionist, Dr. Vivek Agarwal. And Dr. Soumya is a final year DM resident, and she'll be discussing this article today. As both of you had given a very good introduction, and it's a very important topic. The way this field is evolving, now people are looking at highly selective patients, even in the late window period, who can benefit. And not only the core. Now the way the research is setting is, they are going to distal vessels. So the technology is advancing and changing. So it's an exciting time for acute stroke treatment. So over to Dr. Soumya.
Good evening, respected chairpersons and faculty. I'm Dr. Soumya, final year neurology resident in CMC Ludhiana. I would like to thank IA in stroke subsection and Professor Jairaj for giving me this opportunity. The article for today is an original article which was published in NEJM in February and was updated on April 6th. The title is Trial of Endovascular Thrombectomy for Large Ischemic Strokes, The corresponding author and the first author is Dr. A. Saraj from Cleveland Clinic. So as we know, endovascular thrombectomy has been shown to be effective in reducing disability than medical therapy alone in patients with cerebral large vessel occlusions, especially in patients with anterior circulation strokes. And so strokes with large core have been underrepresented in thrombectomy trials, though they constitute about 1/5 of large vessel occlusion related strokes. Hence, the safety and efficacy of mechanical thrombectomy in patients with a larger ischemic burden has not been well established. So the ischemic burden can be detected on imaging by various modalities. First, we have the non-contrast CT scan where aspect score is used, which is a scoring system which has 1 to 10 points. And in the MCA territory, each area involved, we see that the lower the score, more severe is the infarct. And then we have the CT perfusion, where quantitative brain volume is measured in regions with critically reduced brain volume and the infarct and the penumbra. And we have the MRI DWI, where the brain tissue affected is shown to have cytotoxic edema. So the current guidelines regarding mechanical thrombectomy, that is the American Heart Association and 2018 guidelines, show that for individuals with acute anterior circulation stroke due to large vessel occlusion, aged more than 18 years and NIHS score of more than or equal to 6, aspects of more than or equal to 6, and presenting within 6 hours of symptom onset, the evidence is 1A. This evidence is mainly generated from 5 large thrombectomy trials, that is the Mr. Clean, ESCAPE, Revasc, SWIFT Prime, and Extent IA. And this is the Hermes collaboration meta-analysis, which has given the number needed to treat is 2.6, and hence the recommendation is based on this meta-analysis. So for anterior circulation strokes with lower aspects, that is aspects of less than 6, we have within 6 hours, the recommendation is 2B and B. And for extended window mechanical thrombectomy, that is within 6 to 16 hours, the level of recommendation is 1A, that is only based on the dawn or diffuse criteria. Whereas for window between 16 to 24 hours, based on the dawn eligible criteria, the recommendation is 2A, B. So what are the dawn and diffuse criteria? For in diffuse 3 criteria, the time window is 6 to 16 hours, where they have taken clinical and imaging mismatch in individuals more than 18 years of age with NIHS of more than or equal to 10 and infarct volume of less than 20. Whereas in individuals less than 80 years of age, infarct volume NIHS of is between 10 to 19 and more than 20, and the infarct volume is less than 31 and 31 to 50 respectively. Whereas in dawn criteria, the window is 6 to 24 hours, and the target mismatch profile based on the dawn criteria is maximum core of less than 70 ml and mismatch ratio of more than or equal to 1.8 and mismatch volume of more than 15. And we have the European Stroke Organization 2019 guidelines, which say that for LVO-related acute anterior circulation ischemic strokes with the extensive infarct core, that is aspects of less than 6 on non-contrast CT or core volume of more than 70 or 100, to be included in randomized control trials comparing mechanical thrombectomy plus medical management versus medical management alone, and the evidence for this is very low. So what is the current evidence we have for trials for large, what are the trials for large core infarcts? So this is a study which is called the SELECT study, which is a pilot study, a prospective cohort study, which was which was performed in United States. Sorry, sir. One second.
Yeah, correct.
Sorry, sir, for that. This is a select study which based on which the current trial is calculated. So this study is a prospective cohort study which is based in 9 US centers where anterior circulation large vessel occlusions up to 24 hours were taken, and the ischemic core that was taken was CT aspects of less than 6 and CT perfusion core of more than 50 ml. So this study showed showed benefits favoring endovascular thrombectomy, that is 31% versus 14% in the medical management arm. And we can see the MRS shift analysis, which shows favorable MRS in favor of the thrombectomy arm.
Hello. Yes.
This is a systematic review and meta-analysis, which is based on a small cohort studies of large core endovascular thrombectomy trials. So this meta-analysis has taken into consideration aspects of less than 6 and CT core volume of more than 50, MRS of 0 to 2 was the outcome that was taken. So according to this analysis, the endovascular thrombectomy group was better in outcomes of 27.7% versus 3.7%. And symptomatic intracranial hemorrhage also was more in the EVT group compared to the medical management group, that is 9.2% versus 5.5%. So the aim of the current trial is to evaluate whether endovascular thrombectomy within 24 hours after stroke onset leads to better functional outcomes than standard medical care alone in patients with acute anterior circulation ischemic stroke with large core volumes. So the Picot statement is the patients taken where patients with stroke due to ICA or M1-MCA occlusion, and the intervention was endovascular thrombectomy plus medical care. Comparator was medical care alone. Outcome was primary outcome was MRS score at 90 days, and there are various secondary outcomes which I'll be discussing. And the follow-up duration was 90 days. So the hypothesis of the current trial is the null hypothesis is that mechanical thrombectomy has a similar outcome as medical management in achieving favorable MRS outcomes at 90 days in acute anterior circulation ischemic strokes, randomized within 24 hours, whereas the alternate hypothesis is that mechanical thrombectomy is superior to medical management alone in these patients.
Large core.
Yes, large. The study design, this is a phase 3 international randomized open label trial with adaptive enrichment design and with blinded endpoint assessments. This was conducted across 31 centers in United States, Canada, Europe, Australia, and New Zealand. And the Data and Safety Monitoring Board oversaw the safety and interim analysis. This board consists of neurologist, interventional neurologist, and vascular neurologist. And all imaging was reviewed by a central core laboratory, which was in Cleveland Clinic. And the funding was by Stryker Neurovascular, but this funding agency had no role in design of the trial, writing of the manuscript, or analysis of the trial. So the inclusion criteria were patients aged between 18 to 85 years with acute ischemic stroke in the ICA or M1 occlusion, NIHs of more than or equal to 6, aspects of 3 to 5 on NCCT, CT perfusion based on either CT perfusion, that is score was calculated based on either the CT perfusion or MRI, that is the ADC value was taken, which has to be more than or equal to 50 ml. And pre-morbid MRS of 0 to 1, and there should be no evidence of intracranial hemorrhage on neuroimaging. The endovascular thrombectomy has to begin within 24 hours of last known normal. The exclusion criteria were inability to undergo either CTA or CTP, very large course that is aspects of 0 to 2 was excluded from the current trial. And other conditions like intracranial tumors, flow limiting ICA or aortic dissections, and intracranial stents which were in the similar vascular territory where similar vascular territory where MT has been planned. And IV thrombolysis, either alteplase or tenecteplase, was administered in this trial to eligible patients within 4.5 hours window. And patients with tandem occlusions or isolated cervical occlusions were also taken in the trial. Randomization was done in a 1:1 fashion to the EVT and medical management or medical management alone. This was a central web-based procedure, adaptive procedure, and the adaptive procedure managed to balance key clinical and imaging characteristics, that is the age, NIHs, the ischemic core volume aspects, presence or absence of perfusion or diffusion mismatch, affected brain hemisphere, and the participating centers. And this is an open label trial, but the outcome adjudicators were blinded. Clinical assessments were done at baseline at 24 hours, 5 to 7 days, 30 and 90 days. This was done on follow-up assessments were done either telephonically or with direct visit. And all patients had undergone NCCT head, either CT angiogram or MR angiogram, and CT perfusion or perfusion diffusion MRI. And all the imaging parameters for the calculation of core was done through an automated software that called the RAPID software. Endovascular thrombectomy was performed with stent retrievers, aspiration devices for both. Medical care was in accordance with the AHA, ESO, and the Stroke Foundation guidelines. Stroke Foundation guidelines are the New Zealand and Australian guidelines. And the decisions regarding oral antiplatelets, decompressive hemicranectomy was according to the local practices at the recruiting sites. So this is the randomization algorithm. So once the patients were excluded, the patients with profile of aspects 3 to 5 or perfusion imaging with core of more than 50 ml were taken into the study. And accordingly, they were grouped into certain groups, that is group 1 and 2. So these patients with in group 1 had aspects of 6 to 10 and infarct core volume of more than or equal to 50, whereas group 2 had aspects of 3 to 5 and core of less than 50, and aspects group 3 is aspects 3 to 5 and core of more than 50. So group 3 had both unfavorable CT and unfavorable perfusion. So the primary outcome was the ordinal score on MRS at 90 days. The score was assessed in person or by telephone, and the outcome assessors were blinded. The secondary outcomes were functional independence at 90 days. Functional independence was MRS score between 0 to 2, and independent ambulation, that is MRS between 0 to 3. Procedural complications, successful reperfusion was taken as sticky 2B to 3. 2B is more than 50% of the vascular territory is supplied, but the distal territory has incomplete perfusion, whereas TICI 3 is complete perfusion of all the distal branches. Then the discharge location was another secondary outcome where they have seen if the patient was discharged to a nursing home or was a discharge home or a care facility. Then early neurological improvement, that is reduction of more than or equal to 8 points on NIHS score from baseline to 24 hours, or at 24 hours, if the NIHS score was 0 to 1, it was taken as early neurological improvement. And also the quality of life domains were analyzed. The safety outcomes were symptomatic ICH. Symptomatic ICH was defined as parenchymal hemorrhage type 2 or remote parenchymal hemorrhage associated with an increase of NIHS of 4 or more points on 24-hour follow-up, and neurological worsening, that is again an increase of 4 or more points on NIHS at 24 hours of presentation. Then procedural complications and death. So certain subgroup analysis was taken. These pre-specified subgroups were according to age, NIHS score at presentation, the time to randomization, mismatch profile, and if whether the right or left hemisphere was involved, the occlusion site, and the geographical location involved. So the subgroup analysis in this trial was not powered to make any conclusions. So the trial conduct, so they have two pre-specified interim analysis in this trial, that is at where once 200 patients have been recruited and then once 380 patients have been recruited. And they also had a efficacy and futility boundary. The first interim analysis was conducted at when 200 patients were recruited, and the board has advised to continue the trial. And later on, the board has, before reaching 380 patients, the board has advised to perform an interim analysis, as the Rescue Japan trial was published, and they wanted to check the efficiency. So after 300 patients were recruited, the trial was stopped, and it has reached the pre-specified efficacy boundary in favor of EVT, hence it was stopped. So the sample size was calculated based on this pilot study, that is a select prospective cohort study. And this trial was designed to have a maximum sample size of 560 patients to achieve 90% power at two-sided alpha of 5% to detect a mean standard difference of 0.34 for a shift across outcomes in MRS scores between the groups. The primary analysis was on the basis of intention to treat principle, and they've used a two-sided Wilcoxon-Mann-Whitney test for superiority to assess the distribution of MRS scores at 90-day follow-up. And the superiority value of greater than 0.5 was taken, and also generalized assumption-free odds ratio of greater than 1 indicated improvement of outcomes in the thrombectomy group. So the consort diagram, total of 958 patients were assessed for eligibility, and for various exclusion, they were excluded, and 352 patients were randomized, 178 in the EVT arm and 174 in the medical management arm. In the EVT arm, one patient was lost to follow-up, and intention to treat was analyzed in 178 patients, and as treated population was 180 because 2 patients had crossed over from medical arm to the EVT arm, and per protocol population was 174. 4 patients were excluded because they didn't meet the pre-specified protocol. Whereas in the medical management arm, total of 174 were analyzed according to the intention to treat principle. As treated was 172, and per protocol population was 160. So coming to the results of this trial, the baseline demographics of the patient population in both the endovascular thrombectomy and medical group, we can see that all the baseline parameters are almost equally distributed, and the median age was about 66 to 67, And predominant ethnic group was whites, that is 74% across both the groups were whites. And the occlusion location was in the M1 territory in 51% of individuals, ICA in 44% and 37% respectively. Tandem occlusions, we can say it was slightly higher in the EVT group, that is 31.5% versus 25.3%. And intravenous thrombolysis was performed in 20.8% in the EVT group and 17.3% in the medical care group. And in the EVT group, 58% of the individuals were given general anesthesia during the procedure. So the median interval between the time the patient was last known to be well and randomization was 9 hours across both the groups. And the imaging that was used for ischemic pore volume estimation was CT perfusion in about 97 to 98% of the population. And the overall core volume was 81.5 ml in the median was 81.5 in the EVT group and 79 in the medical care group. Coming to the outcomes, the primary outcome of median score on MRS at 90 days was in favor of the endovascular thrombectomy group. That is, it was 4 versus 5 in the medical care group, with a odds ratio of 1.51, and the superiority that it achieved was 0.6, and the confidence interval was 1.2 to 1.8. The secondary clinical outcomes, we can see similar outcomes, that is favoring endovascular thrombectomy across all the domains in the secondary outcome. That is, functional independence was better in the EVT arm. Independent ambulation was also better in the EVT arm. And discharge location was home in about 10% in the EVT arm, whereas it was only 5% in the medical care arm. Whereas early neurological improvement was more in the endovascular arm, but was not very significant. Even the quality of life domains were all better in the endovascular arm. This is the shift analysis across the MRS groups, which shows that a favorable MRS of 0 to 3 is more in the thrombectomy group compared to the medical care group. That is, MRS of 0 to 2 was about 20% in the EVT group versus 7% in the medical management group. 0 to 3 MRS was 37% in the endovascular group and 18% in the medical management group. Coming to the safety outcomes, symptomatic intracranial hemorrhage was only seen in 1 patient in the EVT group and 2 patients in the medical management group. Early neurological worsening was more in the endovascular thrombectomy group than in the medical care group. That is, plus 24% versus 15%. So early neurological worsening was taken as drop in NIHS of more than or equal to 4 at 24 hours post randomization. And death from any cause at 90 days was more in the medical care, that is 41%. And other access site complications like occlusion, hematoma, and infection were seen, which was lower. But the vascular injury in the endovascular group was significantly more. That is, it was about 18% of individuals had vascular injury, like dissection, perforations, vasospasm, and other complications. So in post-hoc analysis, to see why early neurological worsening was associated with endovascular group, they have seen that at baseline, these patient population had large core, but this large core and the volume was 107 ml among the patients who had early neurological worsening. And in the subgroup and per protocol analysis, the subgroup analysis also was supportive of the primary analysis in this trial. And the protocol and as treated analysis was also done, which was consistent with the primary intention to treat analysis. The efficacy and safety of thrombectomy according to different imaging methods, that is according to various values of aspects, that is aspects of 5 or less was seen in 85% of these enrolled patients, and ischemic core of more than 50 ml was seen in 87%, and both aspects of less than 5 and core volume of more than 50 was seen in 78% of these individuals. And even in these subgroups, the analysis showed that it still had benefit with the endovascular group than the medical management group. Also with large cores, that is more than 100 and 150 ml also, it still showed benefit, but the functional independence was less in this population. This is the subgroup analysis, which was not powered to form conclusions, but all the subgroups showed odds ratio of more than 1 in favor of endovascular thrombectomy. This is for both individuals with less than 70, more than 70 years of age, and also NIHS. And also the ischemic core volume, whether it was 70 ml, 100 or 150 ml. In aspects of aspects 3 to 5, it showed favoring endovascular thrombectomy group. And the subgroup A and B, they have divided. That is, subgroup A has was taken as individuals presenting within 6 hours with NIH with aspects of more than 5 and core volume of less than 70, whereas subgroup B was aspects of less than 5 and core of more than 70. But we can see in both these subgroups, the odds ratio is favoring the EVT arm. To discuss this trial, so the results of this SELECT-2 trial, which involved patients from different geographical regions, showed that endovascular thrombectomy plus medical management resulted in better clinical outcomes than medical management alone in patients with large ischemic core who presented within 24 hours from the last known to be normal. And the incidence of symptomatic ICH was low in this population, but procedure-related complications were higher. They were about 18%. Early neurological worsening was numerically more in the endovascular thrombectomy group, and it was associated with worse functional outcomes at 90 days in the post-hoc analysis. And a potential cause for this deterioration, the hypothesis, is because of brain edema associated with reperfusion. Previous trials which have been done on a large core have shown significantly more rates of symptomatic ICH than in this trial, and this finding was unexpected in this population. So these are the recently published large core trials. That is the SELECT-2, that is the current trial, and then Rescue Japan Limit, which was published in April 2022 in NEJM. Then the Angel Aspects, which was published in April 2023 in NEJM. In the current population, it is in this SELECT-2 trial, it is US, Canada, Australia, and New Zealand. Rescue Japan was performed in Japanese individuals. Angels was performed in China, and the number of patients recruited was about 230 and 225 in the Rescue Japan. Angels, it was 101 and 102 in both the arms, and the age was 18 to 85 in SELECT-2 trial. Rescue was more than or equal to 18. Angel Aspects, it was 18 to 80 years of age. NIHS was more than 6 in SELECT and Rescue Japan, whereas in Angel Aspects, it was 6 to 30. And the eligibility criteria for the current trial, as we have discussed, it is aspects of 3 to 5 and or core volume of more than 50. And for SQ Japan, it was aspects of 3 to 5. And the volume they have calculated mainly based on the CT, plain CT, and also the MR imaging, whereas Angel's aspect also had aspects of 3 to 5, and the core was, they had a limit to the core volume, that is only 70 to 100 ml of core was taken in the Angel aspects. So in both Select 2 and Angel aspects, they have used CT perfusion and MRI ADC and an automated software that is rapid. Whereas in Rescue Limit trial, they have only taken plain CT, and MRI was done in all the patients. And based on the DWI, they have calculated the ischemic core in these patients. The outcome in all the three trials, as we can see, is favoring the endovascular thrombectomy group than the medical management. Intravascular thrombolysis in the Select 2 trial, it was performed in about 20% of the individuals, and in the Rescue Japan, it was 26.7% and 28% in the EVT and medical management arms respectively, and in the Angel aspects, it was 28% in both the arms. In Select 2, they have used both the altiplase and tenecteplase. Only most of the individuals received altiplase. Only about 11% received tenecteplase. In Rescue Japan, they have only given tenecteplase, but it was given low dose, that is 0.6 mg per kg. Angel aspects, they have used both altiplase and urokinase. In symptomatic intracranial hemorrhage, it is lower in the current trial, that is it's only 0.6% and 1.1%, whereas in Rescue Japan, it was 9% in the EVT arm and 4.9% in the medical arm, whereas in Angel aspects, it was 6.1% and 2.7%. Decompressive hemicranectomy, for the current trial, these details are not known, whereas for Rescue and Angel's aspect, it was about 10% and 7%. And death in the EVT arm was 38%, and in the medical arm, it was 41%. In the Rescue Japan, it was EVT 18%, medical arm 23%. Whereas in Angel aspects, it was 21% and 20% within 90 days. According to these three trials, we can see that the outcomes were all favoring the endovascular thrombectomy group. Only the methodology, that is in the Rescue Japan, they have taken the core volume was taken according to the MRI DWI, and it was only conducted in Japanese population. Whereas in Angel's aspect, again CTP and MR DWI perfusion was used, using an automated rapid software, and the main limitation is in this is it was conducted only in Chinese population, and they have used urokinase instead of altiplase in some of these patients, and only less than 1/3 of the patients received IV thrombolysis, which was also same in the Select 2 trial. So the limitations of the current trial is that it had to be terminated early. It was terminated early because, and this would have caused the treatment effect to be overestimated, and the sample size was therefore smaller than the calculated sample size. And for subgroup analysis, this was underpowered, and the treatment was open label, and only the assessment was blinded, as with all the thrombectomy trials. And some patients who were enrolled on the basis of low aspects, later on when the core committee had reviewed, it actually had higher aspects. And only about 20% of patients in the trial received thrombolysis before randomization. And the thrombolysis was lesser in the medical arm than the endovascular arm. And the population is predominantly whites, and South Asian population has not been represented in this. So to conclude, in patients with large core ischemic strokes, endovascular thrombectomy resulted in better functional outcomes than medical care. And the endovascular thrombectomy was associated with some vascular complications, and cerebral hemorrhage, that is symptomatic ICH, was infrequent in both the arms. So to critically appraise this trial, did this trial address a clear question? Yes, it had a clear question of outcomes in large core anterior circulation strokes. Was it a randomized trial? Yes. Were all the patients accounted for? Only one patient was lost to follow-up, and all the patients were accounted. And it was a open label, blinded endpoint assessment trial. And were the groups similar at the start of the trial? Only minor differences were present, but both the groups were almost same in the trial. Were the patients treated equally post-intervention? Yes, all the patients had the medical management and even the rehabilitation up to 90 days was equal in both the arms. How large was the treatment effect? The odds ratio favoring endovascular group was 1.5% with p-value of less than 0.001 and superiority of 0.6. Are the findings relevant to the scenario? Yes. Whether clinically important outcomes considered? Yes. As we have seen, even in guidelines, there's no clear guidelines for large core stroke. So the outcomes are significant. Are the benefits worth the results? Yes, as there are many unanswered questions which have been addressed in the current trial. So after this trial, so the unanswered questions are: what is the benefit in patients with aspects between 0 to 2? And if there is an upper limit for core volume where beyond which the benefit is not seen with endovascular thrombectomy, and subgroups with which could benefit with endovascular therapy has not been adequately addressed in this trial because the trial was stopped early. So the ongoing large core trials are the Tesla trial, which is being conducted in US, and it is the completion date is December 2023, and there's another tension trial in Europe. Then there's a last day trial which is being conducted in France, and all these trials would be hopefully published by the end of 2023. What can we extrapolate based on this trial is that many patients with large ischemic core in anterior circulation strokes are not being considered as candidates for endovascular thrombectomy. So the data from this current trial may support extending the indication for thrombectomy to patients with large core or low aspects on baseline imaging. And more research is needed to define proper subgroups which might have definite or higher benefit in this patient population. Thank you. Thank you.
So thank you, Dr. Soumya. That is one of the very best of the presentations we had in the journal clubs. So congratulations to you as well as your mentoring team. I would, before we make comments from Dr. Pandin or Dr. Rajeshwar, before we
can start with Rajeshwar. Yeah.
Yes, sir. Good evening, everyone. So this trial is very important because in developing countries like India, where awareness about endovascular treatment is very low, so patient often comes late, and by the time they reach to EVT capable center, they have already developed large core infarct and they're out of window period. So this trials give answer that in these section of patient also they can be offered treatment, and there is a good proportion of patients who can benefit from this treatment. And this trial also gives us clarity when we are counseling these patients' family, like what is the percentage of good outcome as well as complication. So it gives us clarity. So hence this trial is important. And I think in future, more studies will come, and as the techniques, sir has already mentioned that techniques are getting refined, so there are better opportunity to treat these section of patients.
So, no, it's I would say, a well-conducted trial, and in a very difficult population, and where the treatment benefit is uncertain. And um, uh, even though the results are overwhelming, but I have few concerns. The three groups that they divided, no, the group 3 is completely unfavorable. And so because the trial was stopped, so we don't have the answers for those three groups, and which group has the highest benefit. And then the other, I won't say it's a issue, but the superiority margin they were able to achieve. So that is good. And very rarely we see trials where achieving the superiority margin. And the one downside I would see is, even though this was done in best of the centers, but the procedural complication. Somebody undergoing thrombectomy and landing up having a dissection or perforation, that will increase the morbidity and also increase the length of stay and the mortality also. So that is probably, it's very odd. I'm not sure. And the other two trials, Soumya, you mentioned, what was the procedural complication? Here's 18%. It's pretty high. That too in best of the centers that they have done. And so that is pretty alarming, even though the ICH rates are very low, but procedural complications, which is very high. And
even the mortality also, Dr. Pandin, 90-day mortality also used to be quite significant.
Yeah,
probably worse than in our general.
That early neurological deterioration, some of these complications would have really pushed it up.
But the mortality is same in both the groups, and not almost.
But you see the general mortality compared to the other groups, around 35. These
I think, Sunil, it's
Dr. Pandey, Dr. Prasad, please.
Dr. Prasad sir is there, so welcome Dr. Prasad for his expert comments.
Yes.
Yeah. First of all, I agree that Dr. Soumya did a good job, and congratulations to her and to the whole team. My points are that odds ratio, if you talk to the patients, even doctors can't make any interpretation of that. So we always talk for doctors, at least, in number needed to treat. So Dr. Soumya, have you done some exercise? What is the number needed to treat?
Yes, sir.
It's not difficult. Not difficult.
Yes, the number needed to treat was about...
For MRS 0 to 2. First tell us about MRS 0 to 2.
Sir, MRS 0 to 2, the number needed to treat was 5.7.
No, there is a 13% difference, no? 20 versus 7. Right? 20 point something versus 7%. So that is 13% difference. That will give you number needed to true up around 8. Right? So 8 patients need to undergo mechanical thrombectomy instead of conservative or usual medical management to have one additional person achieve functional independence, right?
Yes.
And for MRS 0 to 3, it is, what is the number needed to treat?
Yes,
tell us the percentages. What are the percentages?
Yes, sir. The
percentages I forget. Just take the difference, and 100 divided by the difference will tell you the number needed to treat. So what are the percentages? I forgot.
18%, sir. 20.
Don't remember, Soumya? You have
You
read
can
it
go back and
thoroughly.
check.
But anyway, yeah, it is close to the same, 7 or 8, something like that. So when it comes to telling patients about this, if the patient is like an average patient in the trial, then you either explain in terms of absolute difference, or if you think it can be interpreted, certainly doctors interpret it better, you talk in terms of number needed to treat. This odds ratio doesn't make any headway as far as communication with doctors or patients are concerned. So that is one point which you may like to keep. Many physicians may be persuaded to go for it. Some may still not be persuaded, and let us wait for some more data to see whether they are convincing enough, or let's say at least the benefit gets enlarged, because as the practice is going, perhaps people are getting better and better, and then technology is also improving, and maybe it turns out to be better than what it shows in the current trials. Two important points about this study is, why is hemorrhage or symptomatic intracerebral hemorrhage less? This is something which we need to worry about. 2 points which appear very, at least related with that. One is that there was less incidence of thrombolytic intravenous thrombolysis in this patient, right? 20% as compared to 26% and something else. Second thing, which is a competing explanation, is that the ischemic core was also smaller as compared to the Japanese and Chinese trial, right? And we know that bigger the ischemic core, greater is the risk for intracerebral hemorrhage. And but same maybe alternative explanation, perhaps less convincing, is that if you use thrombolysis, intravenous thrombolysis more often, then you are definitely going to have increased risk of intracerebral hemorrhage. Now, how can we dissect out which one is responsible in this? That I think you will have to wait for another paper the same group will publish. And my guess is that it will turn out to be the volume of ischemic core which will determine the rate of hemorrhage, and they will do some individual patient data meta-analysis to tell us who are at risk of developing this intracerebral hemorrhage. But complications are concerning for me also, as Dr. Pandya was pointing out. 18% is quite significant, but outside the trial, it will be more for sure. It will be more than 18%. You should be prepared to have even up to 25%, because in trials, people are more cautious. They are more, you can say, geared to meet the requirements of the study. When outside the trial, when it gets implemented in practice, usually complications rate increase. But positive side is, as people get more expertise, they will obviously have less complications. So only time will tell, and maybe these 3 trials which are ongoing may add some information on how to avoid this. So that is, I think, otherwise trial is well conducted. These days, stopping trial early is considered a negative quality criterion for randomized trial. And general advice is that once you have calculated the sample size, you complete it. That usual concern, which was ethical, is gradually getting diluted, because actually you overestimate the effect, because you stop the trial at the peak of best performance of the let's say trial result. And then if you add all the trials stopped early, then you exaggerate that benefit, and obviously it doesn't get translated into practice. So trials stopped early has become now, even in Cochrane reviews, this is one of the criteria for rating down quality of the trial. But obviously, investigators don't have a control. It is the data monitoring committee deciding. Why did they stop early in this case? Do they give any details about that?
Yes, sir.
Given, sir. I think there are two things. One, they are telling that they had already made a decision to have to interim analysis, and they had gone ahead after the first 200, and then when the Japanese trial results were published, I think the data monitoring committee asked them before reaching that second pre-decided point of interim analysis, they asked them to check the data. And they also made a statement, I didn't understand the meaning of it. The statistical analysis was already planned before the 1 day difference, 1 day before the date of the data monitoring committee asking them to do the second interim analysis. So I don't know why
Let Dr. Soumya also answer.
Yes.
Dr. Soumya, you are saying something. You are the student, you should answer. Tell.
Yes, sir. After the first interim analysis at 200 patients, they had decided to continue the trial. And when the Rescue Japan Limit trial was published, then they've been advised by the board to conduct an interim analysis, and they also have the futility and efficacy endpoints that were predetermined. So as it had reached the efficacy and superiority, they've decided that at 380 at 300 patients to stop the trial.
Now, that's fine, because still a data monitoring committee considers it unethical to continue the trial when superiority has been observed, and that is why they advised the steering committee to stop the trial. So steering committee doesn't actually have so much say into that. It is influenced by data monitoring committee. About the subgroup, this is a very common question and common conclusion from all the trials. Trials successful, it definitely benefits, or the intervention is beneficial, but we don't know to which subgroup this is going to benefit more as compared to less. Now, this question has been answered, at least partly, in design of the trials by Salim Yusuf, who wrote a very good paper, which has more than 1,000 citations, I think. Why do we do large sample trials? In which he has actually the direction of effect of an intervention usually remains similar across all the subgroups. It is very unusual to see that one subgroup is being harmed as compared to another subgroup which is being benefited. Whenever people have tried to do this, like if you remember, maybe you were too young at that time, when so direction of effect generally remains similar across all the subgroups. So how will we know? Basically, it is good to go by the average effect. The average effect is likely to be true across the subgroups, except in few situations where there are certain criteria to be fulfilled. And that is, of them will accumulate the data and do some subgroup analysis that is possible. Each individual trial cannot do it. Still, it is unlikely that you will find some sometimes. So don't be too optimistic about subgroup. So it will be only after all the 6 trials are available, but still you can use your judgment and apply the results of the trial results, which you have presented very well.
I asked all the other participants if they have any queries to ask to Dr. Prasad, Dr. Jairaj Pandian. You please, and Dr. Rajesh, please shoot your questions. And you can ask, Asmita, please unmute everybody and if there are any questions more.
Okay, sir.
I think, sir, I'll just comment on the hemorrhage part. And if you look at the Chinese trial, they had given urokinase. That is a standard of practice there in China, intravenous urokinase and alteplase, either of those 2 drugs. Maybe that could be one reason there. But the proportion is almost similar, the IVT, in all these trials. And so there could be some effect of those thrombolytic agent also. I think we don't have any questions.
Dr. Prasad, sir, you would like to respond? Prasad sir is unmuted.
It's fine. The incidence of or the frequency of use of intravenous thrombolysis is certainly bigger in the Japanese and Chinese trial as compared to this trial. But it is not so big that it will completely explain the differences in the rate of intracerebral hemorrhages. Because you see 20% versus 26%, but hemorrhage difference is, I think, too big to be explained by that. But yes, as I was trying to say, that ischemic core size is probably going to stand out more because it is, again, quite a big difference between the 3 trials. Certainly from our trial, today's trial, which we discussed, versus the other 2 trials. So we'll see when all 3 trials, they do individual patient data meta-analysis. If you ask me to predict, I will predict that the intracerebral hemorrhage will relate more to the ischemic core size. But a candidate or contender will be frequency of use of thrombolysis. We'll see. Time will tell.
Thank you, sir.
So I have a small question. Yes, Dr. Gorti, go ahead.
No, there are no questions, I think, from the
I want to ask a small question, sir. The around 20% of the patients are blacks. So blacks have been covered. And we have some Chinese results, independent study also. But South Asians participation from US, Europe, plus Canada, Australia, New Zealand, hardly any, very small percentage. So coming to the interpretation of the results to our population, can we use it or we need independent studies? What's your thoughts on that?
If we had enough money, if we were like, spending as much money as US does on research, then yes, we should dismiss this study, do our own study. But so far, we haven't got enough money to conduct our own study. You see, the US has not cared at all about tenecteplase, little bit, some statement, very wishy-washy. Unless Boehringer Ingelheim spends huge tons of money in the US and conducts or completes these tenecteplase studies, neither US FDA nor US people nor US associations will even look at the results which are coming from other parts of.
Yeah.
There are 2 questions here. One is Jitendra Sharma says, what type of MT this trial used?
You can see China is doing a lot of trials on their own. But yes, we should hope that someday we will have our own trials before we implement results. At this time, I don't see that happening. So I don't see an independent trial happening in India before we reach a point, tipping point, when we will start following the results?
There are 2 or 3 questions which we should answer. One is the type of empty that has been answered. The second question is etiological diagnosis had any effect on the outcome. That is one question. Second was 0.6 milligrams per kg alteplase recommended in Indian population. That is Sita Lakshmi. So any experts can answer these 2 questions.
Yeah. So what type of empty this trial is? I think this is a industry-sponsored trial. Probably they would have used.
They have.
Dr. Pandyan, but they are telling that even though Stryker has actually funded it, they had allowed all the participating centers to use their own.
Yeah, it was up to the discretion of the investigators. Yeah.
Operator. Yes.
But actually, what they use, we don't know. They actually have full freedom.
They have said they have mentioned that endovascular thrombectomy was performed using stent retriever aspiration devices or combination of both. So as per, I think, operators' choice and patient criteria they have used.
Okay. That the question is etiological diagnosis has any effect on the outcome?
So should I answer that?
Yes, sir. Yes, sir.
You see, the etiological or etiology of ischemic stroke is so varied that even you know that when we say atherothrombotic, it is still a heterogeneous group. When we say cardioembolic, it's still a heterogeneous group. So actually, there are so much heterogeneity about causes that for each cause, it is difficult to arrive at conclusion. So what randomized trial does is take all causes which you observe commonly, randomize, make them into 2 similar groups and see whether it works. So there will be always more questions than a trial can answer. Can we answer the question about etiology? No, we cannot, because if you go by etiology, there will be small numbers in each subgroup, and it will show up as if the effects are similar across the etiological strata.
Another question is at 0.6 milligram per kg alteplase. Can it be recommended to Indian population?
That is what the Japanese used.
Means because of the thin body space area, thin build, and that is, they did the trial in 0.6 milligrams. So as per the national guideline, they use it. And for Indian population, even though we participated in the Enchanted trial, but not in the TPA arm, 0.9 versus 0.6, we just participated in the BP arm. And so we need to, even though people say the Asian population require 0.6 milligram, but the Enchanted trial does not show any difference in terms of ethnicity. So we need to, this is my view, that we need to continue to use 0.9. Yeah.
I think that's all for the question.
One last,
Dr. Gothi, you are not. It is good that you are not asking me this question.
There is one question in Q&A section.
Yeah. No, I think we have answered all the questions.
No,
one more, just now one question.
Yeah, one more just now. Does the use of alteplase versus tenecteplase affect the outcome in this trial?
Very few tenecteplase.
Yeah, Soumya, what percentage received?
It was used in 11% in the EVT arm and 3% in the medical management arm. So rest all were alteplase.
So it's a small number. So.
The very large number of patients
are so small that we cannot answer this question. In fact, if at all one wanted to, if ever we designed a trial, we better design with tenecteplase, and then we see what happens. That number will give us some answer.
Yeah. So we have this trial in the Instruct. Dr. Rohit is the PI, looking at LVOs within 4.5 hours, randomize them to alteplase versus TNK. So it is recruiting well. Sample size is around 360, if I'm correct. We have reached around 42 or 43. So.
The use of rapid to make this volume size etc., and also for the aspect scoring. Is it some kind of a affirmation that RAPID is getting sufficiently established, so that what do you?
My personal opinion, we got it for a year with some local funding we had, and it doesn't really. It's not really helpful, I would say. This is my personal view, and the simple CTN aspects, that's sufficient to take a call. Yeah.
But these two of these major trials on this large core thrombectomy, they have used only RAPID for all the classification. So that's a bit, anybody else? Dr. Gorti using RAPID? Please, you are artificial intelligence person.
No. Here, no. We are in the process of developing one algorithm, but here Dinanath Mangeshkar is using, and so they are having a large number of cases for them. But we are in the process of developing the algorithm and volume calculation and the collateral calculation software based. So this is work in progress.
It's a learning curve, isn't it? It's really yeah.
Sir, I couldn't hear the speech.
Yeah, I agree. It takes time to gain confidence.
Yes, sir. It takes time.
It's also very, very expensive, and every year you have to pay huge.
Now it is 30 lakhs per year.
Yeah, it's pretty expensive.
30 lakhs per year. So,
Seems RAPID was provided to all the study centers in the study. That's what they have written. That's.
So I think we had a very good discussion, and Dr. Prasad sir, Dr. Jayaraj Pandyan, and Dr. Rajeshwar and Dr. Soumya, Sunil, we all had good discussion and a wonderful journal club. Shall we close the session?
Yes. Thank you. Thank you very much.
Thank you, sir.
Thank you.
Good night. Good
Bye.
night.
Thank you very much to all of you. Thank you.
Thank you, Dr. Soumya. You did a wonderful job.
Thank you. Thank you, sir.
Okay.